Good morning, everybody, and welcome to this morning session of Breakfast CME. Today, we have a very active and vibrant couple as speakers. They are not only good academicians, but they are a great asset for the Allahabad Medical Association. So, we have Dr. Pankaj Gupta and Dr. Varsha Gupta. Dr. Pankaj Gupta will be speaking on the topic neurosurgery update, and Dr. Varsha Gupta will be highlighting issues of clinico-pathological issues of renal disease. So I now hand over the mic to Dr. Anubhav Srivastava to conduct the scientific proceedings.
Good evening, everyone, for yet another session of Breakfast CME. With the tradition, as Sir said, we'll be having two sessions by young dynamic speakers. To start the scientific session, with the permission of the chair, I would like to start with by inviting our chairpersons for today.
Thank you, sir, for your kind words and blessings. Respected dignitaries on the dais, honorable esteemed audience, my respected seniors and friends. Good morning to all of you. Akhanda mandalakaram vyaptam yena characharam tat padam darshitam yena tasmai shri guruve. Before starting my talk today, I want to convey my sincere regards and my gratitude towards my teachers, Professor Chauhan sir and Professor Gopal sir, who have taught me the ABC of neurosurgery, and still they are along with us, guiding to excel in this field. Neurosurgery is a very vast topic. It has got many subspecialties now in the form of endovascular surgeries, minimal invasive spine surgeries, spinal deformity corrections, skull-based tumors, vascular surgeries, pediatric neurosurgeries, and so on. Lots of subspecialties are now complete. We are trying to start each and everything at our setup at PMSSY building SRN Hospital. Hereby, I am representing my Department of Neurosurgery, SRN Hospital. Like this picture, in this picture, this small baby bird chick is trying to open its wings and trying to fly off the edge under the guidance of its mother bird. So likewise, we are also trying to open our wings towards different shades of neurosurgery under the guidance of our able teachers. So coming to my topic, I'll be trying to cover each and every subspecialties in super specialty neurosurgery, which we have started recently. Coming to my first case, there's a 35-year-old lady who has presented with sudden altered sensorium, severe headache, and vomiting. When CT scan was done, there was blood in left sigmoid fissure, which was suspicious of aneurysmal bleed. CT angio was done, and it was showing a saccular aneurysm over the left side of MCA bifurcation. Patient was planned for surgery, and after opening, we usually take perineal craniotomy in these cases. I don't want to get into details of how we do surgery, because that will be the, I think that will not be feasible here. So after opening the sylvian fissure, we define different anatomies, and we dissect this aneurysm at its neck, and we apply an aneurysm clip at the neck to obliterate it completely. This is the post-operative CT angiography. You can very well appreciate aneurysm clip, donated aneurysm clip at the neck of this aneurysm with patency and distal flow of distal branches of MCA was intact. This is the post-op image. There was no infarct or venous edema. This is the 3D reconstruction image of CT angio, which is clearly showing that distal branches are absolutely patent. And this is the patient which recovered perfectly with the slight hemiparesis, which recovered in next 6 weeks. Another case, the same presentation. Lady was 65-year-old female, hypertensive, and she presented with altered sensorium, severe headache, and with vomiting. On CT scan, plain CT scan, this is also an educational program. So each and everybody should be able to understand how these subarachnoid hemorrhages, especially aneurysmal bleeds, how they present. These patients are usually hypertensive or they can be normotensive, and they present with severe unrelenting pain in the head. Sometimes they call it as worst headache of my life. In these cases, if we are getting this sort of finding, small bleed, subarachnoid hemorrhage over the Sylvian cistern or anterior interhemispheric fissure, that is suspicious of aneurysmal bleed. In this case, we went for CT angiography and it showed a giant aneurysm over right MCA bifurcation, which was projecting posteriorly and laterally. This is the aneurysm, this is the 3D reconstruction image, and the aneurysm is well seen. Same approach, tenioral craniotomy, and since it was a giant aneurysm, so the clip was not sorting out the purpose. It was in the neck of the aneurysm completely. So we used tandem clips. We applied 2 clips from both the sides to obliterate it completely, and the distal flow was all right. The lady recovered immediately and she was all right. There was no post-operative deficit. This is another case. It is a little bit complicated. Patient was hypertensive. She presented in loss of consciousness and history of sudden severe headache with vomiting was there. On CT scan, there was blood in anterior interhemispheric fissure and suprasellar cistern, which was query suggestive of aneurysmal bleeding. So we went for CT angio, and this CT angio was showing a saccular aneurysm over the anterior communicating artery. This is the ICA, it is bifurcation, this is MCA, and this is ACA. So this is the left side of ACA, and here it is anterior communicating artery. Anterior communicating artery aneurysms, they are difficult to operate because they are in the center of the circle of Willis, full of vessels all around, and you have to take afferent controls from both the sides. Afferent and efferent controls we have to take on the both sides. Both ACA should be dissected, both A1 and A2 should be dissected. So it's a difficult task. In this case, we have operated it in BMSSY. This is how the anatomy we dissect out in the cases of aneurysms. After opening the Sylvian fissure, first thing we see is optic nerve. This is optic nerve. ON is optic nerve. Then comes the internal carotid artery. Then we follow the internal carotid artery. We keep on splitting the arachnoids over the internal carotid artery. So then we come to bifurcation of ICA, which shows ACA and MCA, anterior cerebral artery and middle cerebral artery. Then we follow the anterior cerebral artery. Then we dissect the cerebral artery A1 and A2. Then comes the anterior communicating artery. Same we dissect on the contralateral side also. Apply temporary clips. Then we dissect out the neck, and then we apply the aneurysm clips over the neck to obliterate it completely. And thereafter, the temporary clips are removed. This is the second picture. In this case, this is the aneurysm clip. I don't know whether it is appreciable or not. This blue color aneurysm clip is there. This is the post-operative CT angiography. Here it was aneurysm, here saccular aneurysm. This lengthy material is actually aneurysm clip, and now the aneurysm is not visible in post-operative scan. This patient was all right for 7 days. Actually, in this case, the right side, opposite side of anterior cerebral artery was hypoplastic. So in these cases, you don't have actually collateral supply. If these cases land up in vasospasm, then it is to manage them. Unfortunately, this lady was all right for 7 days, but after 7 days, she developed vasospasm. And because of lack of collateral supply from the opposite side, we couldn't save this patient. Another patient, 65 years old female patient, she presented in status epilepticus and coma. On CT scan, there was a large bleed on the right side of frontoparietal region. We went for MRI. MRI was showing multiple rounded lesions over the right frontoparietal region, and it was filled with intratumoral bleed. The CT angio was done, and CT angio was unremarkable. So it confirms the diagnosis of cavernous. So these are multiple cavernomas with intracavernous bleed. This lady was operated by craniotomy, and after doing the craniotomy, we removed it completely by transsulcal approach. Since it was anterior to the motor plate area, So we were in mood not to touch the motor plate area, or we were not in mood to sacrifice the brain material. So we just split the sulcus and we take out whole of the tumor without sacrificing even a single centimeter of brain cortex. So post-operatively, this patient was all right, her hemiparesis improved, and she was discharged on day 5 only. This is a post-operative scan, absolutely remove all the tumors. Another large tumor, it was a huge bi-compartment tumor, and it was originating from both superior and inferior leaves of tentorium cerebelli. The major chunk was going inside the middle cranial fossa in infratemporal region, and the minor chunk was in the CP angle region. So this is the middle cranial fossa part, this is the posterior cranial fossa part, and it was compressing. This is the brainstem, which is compressed. Brainstem of fourth ventricle is compressed, and it is pushed to the opposite side. In this case, we have taken occipital and suboccipital craniotomy in a single piece, and with preservation of transverse sinus. This is the transverse sinus. The tumor was taken from both the fossas completely. This is the tumor material, and the biopsy was grade 1 meningioma. This lady improved very well, apart from little bit of facial weakness. Otherwise, she was all right. Post-operatively, she developed little bit of a surgical site infection, which responded well to the conservative management. Now she is all right. This is another case of CP angle tumors. Routinely, we are doing CP angle tumors almost every week, but this was a little bit interesting and rare case. In this case, luckily, we got this patient of double tumor in CP angle. This is a very rare tumor. So it is called as collision tumors. So we were having in this picture, I think we all can appreciate two consistencies. This consistency is suggestive of epidermoid tumor, and the other one, this tumor, this is vestibular schwannoma or acoustic neuroma also, we can say. This lady has presented with facial numbness, facial weakness, and along with that, she was having hearing deficit. We took the retromastoid suboccipital approach, and after this approach, we opened the dura and we took out both the tumors in same sitting. The patient was absolutely all right without any deficit. She recovered, and biopsy was, one was epidermoid, another was vestibular schwannoma. Another case of para-saggital meningiomas. Para-saggital meningiomas, most of the neurosurgeons, they usually get this case to operate, but middle 1/3 para-saggital meningiomas are very notorious, and they have tendency to infiltrate into the superior sagittal sinus. This was a large tumor which was infiltrating the superior sagittal sinus, and patient had presented with headache, seizure disorder, and hemiparesis. On MRI, the superior sagittal sinus was infiltrated. So we had taken patient for surgery, and craniotomy was taken across the midline. This is the midline. This dent is showing the midline, that is superior sagittal sinus imprint. So we had taken across the midline, and the superior sagittal sinus was unroofed. And thereafter, we took out whole of the tumor in a single sitting. Along with that, most of the part which was infiltrated inside the sinus was safely taken out. This is the post-op scan, which was showing no venous infarct, no mass effect, everything was all right. This is the patient on day 5. He was walking normally, only a little bit of hemiparesis was there, which recovered in next few weeks. There's a picture of an unfortunate 13-year-old boy who has presented in coma with status epilepticus. When a CT scan was done, there was a dubious mass in left side of frontoparietal region. We went for MRI, and in MRI, we saw this big tumor. This was variegated consistency, solid cystic mass, brightly enhancing, and it was suggestive of high-grade glioma. Previously, high-grade gliomas were not so common in young age patients, but nowadays frequently we are seeing that patients in 20s, in 30s, in 40s, they are regularly having high-grade gliomas. So in this, this was not a very big case for us, but important thing was that this vein, this bright vein, you must be appreciating it. This was at the base of tumor, and it was a Rolandic vein. Rolandic vein actually supplies the motor plate area. So if we sacrifice this vein, patient is going to have lifelong hemiplegia. So the actual challenge in this case was to preserve this vein along with dissection and resection of whole of the tumor. So we went for craniotomy. We took out whole tumor, and gross-topically it was resected. All around normal brain is visible. At the base of the tumor, this Rolandic vein, we dissected out it nicely, and leaving a thin curve of tumor around it, we separated it. Post-operatively, the boy wake up without any deficit, and he was all right. This is the post-operative scan. Absolutely complete removal of tumor was there, and he recovered very well. Since the biopsy was GBM, so patient was sent to the oncology department for further chemo radiation. Now to complete the list, we are coming to the minimal invasive spine surgeries. This extruded disc at L5S1. We did it with the minimal invasive spine surgery, and we used the standard technique of minimal invasive surgery, just 2 to 2.5 centimeter of incision, and with this we can take out this extruded disc. Patient discharged on day 3. These procedures are very good, but actually they have got limited indications. If we do these procedures on absolute indications only, like single-sided extruded disc, then the results are marvelous. If we'll start doing it in each and every case, trying endoscopic discectomy, like in central disc, like in canal stenosis, then results are not that much encouraging. So it is always good to reserve these procedures for absolute indications. Another minimal invasive surgery. This is a minimal invasive pedicle screw fixation. Especially it is done in osteoporotic fractures or post-traumatic fractures where the height of the bone, height of the vertebral body is lost. Patient is having severe pain, but the limitation of this procedure is that posterior longitudinal ligament should be intact, and it should not be having neural compression, because in this case we can only fix the vertebra, but we cannot do decompression of nerves. So this is the incision site, just 1 centimeter incision, 4 incisions we take for 4 screws, and thereafter we can fix it like this. These 2 pictures I have taken from internet. These are not my own images. It is here for completing the list. This balloon kyphoplasty, actually in 70s, 80s, especially in females as well as in males, when there is a maximum osteoporosis, in those cases, osteoporotic compression fractures are very common. And these patients are usually having very severe low back pain, which does not resolve with any conservative management. In these cases, balloon kyphoplasty is a very good option. It is done in local anesthesia. We need just a single puncture needle. With that needle, we negotiate through vertebra. You can use we negotiate through pedicle. You can use unipedicular, or you can use bilateral pedicular approach. And thereafter, we negotiate into vertebral body. Balloon is dilated, the height is attained, and thereafter, bone cement is filled in that height to maintain the height of this vertebral body to desired height. This was 85 years old male patient having severe pain, and after balloon kyphoplasty he was all right, discharged on next day. Now coming to the CV junction. Craniovertebral junctions are very deadly places. They are having all the controls, central controls. You have got medulla there, you have got upper cervical region there. So you have got all the vital centers there. So here congenital anomalies in the form of atlantoaxial dislocation and basilar invagination is usually found. And these places are very difficult to operate. This is almost 65 years old female patient who has presented with spastic quadriparesis with bladder wall dysfunction. She was not able to walk. Patient had came and they have took the patient on lap only. So on MRI, it was showing there was atlantoaxial dislocation. Actually, this is anterior arch of C1 and this is dens. The distance between anterior arch of C1 and dens, when it increases, then it starts impinging over the cervical junction, like here. And the canal diameter here, it goes down. Because of this, there is compression over the cervical junction. This white signal is showing there is myelomalacia as well. This patient was taken for surgery and we planned for C1, C2 fixation. C1 lateral mass and C2 pedicle fixation was done here. This is after the fixation. This is perioperative picture. So I have taken some measurements to show how it works actually. So I don't know whether it is appreciable or not. There is a marker here. distance between anterior arch of C1 and dens, it was preoperatively 6.8 mm. The normal range is less than 3. After surgery, this distance was 1.4 mm. It was almost abutting the anterior border of dens. So the effective canal diameter, this is the effective canal diameter posteriorly, it got widened up. So now there is no pressure over the cord at the cervical junction. Another measurement which we take is Chamberlain's line. This is Chamberlain's line, and part of dens going above the Chamberlain's line is 7.8. But after surgery, this has come down to 4.6 mm. The ideal target for this dens height over the Chamberlain's line to keep it below 5 mm. So after surgery, it was 4.6 mm. This is clivus canal line. This is clivus canal line. Any amount of dens, if it is going above the clivus canal line, that is regarded as basilar invagination, which impinges on cervical junction. So after surgery, it should come down. Now we can see it is perfectly in abutment with this clivus. This is pre-operative scan of MRI, lots of pressure at cervical junction, myelomalacia, and this is post-operative. Absolutely open cervical junction. Myelomalacia is it is going to be there, but the flow was absolutely all right. This is the lady after 5 days only. You can see she's holding the pen in both hands as well, and she's walking. Another case, it was a difficult case operated by me and Dr. Gopal sir. She was having fixed type of AD. This patient was having fixed type of AD. Anterior arch was attached to the attached anteriorly, and it was attached posteriorly as well. So it was actually occipitalized and assimilated. So in these cases, and she was having very short neck. So anatomy was not actually in favor of C1 C2 fixation. So we went for occipito-cervical fusion. So this is the occipital plate, and we negotiated C3 and C4 cervical vertebral bodies, and this is after fixation. And this patient also recovered well. So what are our future plans? We are actually working on our future plans to start advanced endoscopic brain and spine surgeries. In collaboration with cardiology department, we are talking about DSA and endovascular coiling procedures. We are doing deformity correction surgeries as well. Epilepsy surgery, functional neurosurgery, and advanced pediatric neurosurgery. It's there in pipeline. We'll be surely working. These paraphernalias, because without instruments, you cannot do anything. So these paraphernalias we are having at PMSSY. This Pantero 900 microscope, most advanced. We have got Medtronic micro drills. This Philips Viridius C-arm, and we have got CUSA as well. These are able neurosurgery team headed by Professor Gopal sir, Dr. Amit Singh sir is associate professor, me with Dr. S.D. Pandey, we are assistant professor, and Dr. Saurabh Anand Dubey is there as a trauma neurosurgeon. I'm proud alumnus of England Medical College, as I have done my MBBS and MS from England only, and I've done my MCH from SMS, presently working at the PMSSY SRM Hospital. My sincere acknowledgements to my teachers, my mentors, seniors, colleagues, my juniors, Almighty God, my patients, my family, residents, paramedical staff, anesthesia and pathology team, ENT department, especially Dr. Sachin Jain sir for teaching us transnodal approaches, cardiology department, Dr. Abhishek Sasdeva and Dr. Piyush sir, Allahabad Medical Association and all the office bearers, our fitness team, Two Wheel Thrill group, for encouraging us for doing so much of activities. These are my passions. I do run, I do sing. We together do lots of cycling and we trek. But above and over all my passions, I have the utmost passion of surgery. I'll finish my talk with these golden lines of my favorite shuttler, PV Sindhu, that says, your dreams are what define your individuality. They have the power to give you wings and make you fly high. Thank you for your patience. Any questions from the house, please?
Thank you, Dr. You had very nicely presented the department. It was founded by Professor Chauhan, and now looking after by me and we have represented all the type of surgeries. And I would like to add further that we are also doing the transdisciplinary surgeries with the help of Department of ENT, and we are doing the pituitary surgeries like pituitary adenomas and the pituitary meningiomas pattern also. And we are doing all sorts of newer advanced work in our department. And it is by the help of our young team who had worked a lot, and we are working in coordination very much everywhere inside and outside the department. And that is because of the new team. And in fact, it was because of Professor Chauhan, under whom I was also trained. And because of him, maximum number of neurosurgeons all over India are from our department, and almost in all institutions they are working, as well as they are also practicing outside and doing very good work. And that is very much appreciable in this department, that we are further growing day by day. And it is only because of the institution that we work and we keep on growing. Individually, outside people are doing many good work, but still the department also giving the training to our juniors, and we are also being a mentor to our juniors, and they are also trying. Every year we are having MCA students coming